Currently, with immunochemotherapy being the first line standard of care for mantle cell lymphoma, the current standard of care for relapsed refractory mantle cell lymphoma is BTK inhibitors. The treatment landscape is changing very quickly, though, and we know that we've got increasing use of first-line BTK inhibitors. So the treatment landscape of mantle cell lymphoma is changing, and that's going to dictate what we use second-line and third-line in coming years. But nonetheless, most patients currently who have relapsed refractory mantle cell lymphoma will have a BTK inhibitor as their first choice of chemotherapy, as their first choice of treatment second-line. However, we know that there are certain groups of patients that actually have a relatively short duration of response to second-line BTK inhibitors. And these patients include patients with blastoid disease, patients with P53 mutations, and particularly those patients who have a short duration of response to their first-line treatment. So we know that POD24, this idea of progression of disease within 24 months of first-line treatment, is highly predictive of outcomes to second-line BTK inhibitors. And in fact, ourselves and Diego Villa in Canada published a study looking at outcomes of second-line BTK inhibitors and found that one of the main predictors for duration of response was response to first-line treatment. So I think if you're focusing on who we can improve things on, I would suggest it would be these groups of patients. On the contrary, if you have a patient who has a long duration of response to their first chemotherapy and has second-line BTK inhibitor and gets a CR, they may actually have a very long duration of response on second-line BTK inhibitor. So those patients often stay in remission for a very long time. In terms of how we improve those poor risk patients, there's a number of treatment approaches that people are looking at. The first thing is CAR T-cell therapy. Currently, CAR T-cell therapy, at least in the UK, is licensed and funded for third-line treatment. So one of the things that we're doing in the UK is those patients who we think are high risk as they go into second-line treatment, we're monitoring them very closely. And if they get less than a complete response after 2 or 3 months to BTK inhibitors, we're scanning them, considering repeat biopsies, and considering early referral for consideration of CAR T-cell therapy. Having said that, not every patient is suitable for CAR T-cell therapy due to either financial reasons or geographical reasons, or because it's a toxic treatment. So I think we do need new treatments in this space urgently. In terms of promising combinations, we've seen the combination of ibrutinib plus BCL2 inhibitor being explored, which was presented by Michael Wang at ASH last year and then subsequently at ASCO, and presented, which shows an improvement in progression-free survival with the addition of BCL2 inhibitor with venetoclax with ibrutinib. Venetoclax was given as a limited duration treatment in this study and led to an improvement in PFS of about 7 or 8 months. That didn't translate into an overall survival benefit as yet, but with longer follow-up, we may see an overall survival benefit. Other promising treatment options that are coming into the treatment for relapsed refractory mantle cell lymphoma include bispecific antibodies, and I do think that bispecific antibodies are likely to be highly effective in mantle cell lymphoma. The currently available bispecific antibodies target CD20, and mantle cell lymphoma expresses CD20 very strongly indeed. We've seen some phase 2 data from glofitamab showing high response rates and good duration of response. And bispecific antibodies have the advantage of being relatively easy to deliver, and also are very attractive partners for combination therapy in the future. So I think we are going to see a lot of changes in the coming years for relapsed refractory mantle cell lymphoma. But for high-risk patients, I think in particular, if I had a clinical trial that was open in my centre, that's what I would offer these patients. And I do think we are currently failing these patients with single-agent BTK inhibitors.